So your C-peptide came back, right? And it's still within the normal range, but it's at the very low end of normal, so it's like 0.9. And the lowest point is 0.8. So it very well could be that you're starting, the reason you didn't have DK is you're still probably making insulin. You just might be burning those insulin cells out. It's hard to say for sure. We haven't gotten the other test back yet, but I think with where we're at with the insulin and all that type of stuff, it's probably best to start with insulin. And then if we can, we'll just titrate you off of it outside the hospital.
Okay.
So
What does titrate you off of it mean?
basically means we'll just keep decreasing it while we adjust other medications and see
Okay.
if that helps.
So right now I'm doing the drug that starts with an M.
Right, and you probably won't have that when you go home.
Okay, so because that's not working or it's not going to be strong enough.
It may not do much for you.
Okay.
Yeah.
So, and what it was supposed to do is stop my liver from sending out sugars, right? Or
From converting, it's a
Yeah.
process called gluconeogenesis, which is you take proteins, you break them up and turn them into sugars. It
Okay.
blocks that pathway.
so I know it's just a name, but am I 1, 1.5, or 2 diabetes?
You'd I'd
Or
say
mystery
you're more 1.5 to 1.
Okay.
Yeah, probably.
Which means that when you're type 2, your body doesn't, you're still making the insulin, but your body doesn't like use it right
Recognize it.
anymore.
Yeah.
So I'm not going to be making insulin, something in my body, and we still don't know why.
Right.
It's just either genetic or, but it's
Mhm.
not my pituitary or my thyroid or my pancreas
Right.
or liver or kidneys. All those are good.
Yeah,
Okay.
so they did the cortisol stim tests and all that type of stuff. That all looks fine. Your TSH is normal, so it's, I think it's primarily pancreatic failure. Right?
Okay.
Like the actual cells in the pancreas are what aren't
Okay.
producing enough.
Which are better than having to be cancer or a tumor on it.
True.
Yeah. So is there
Definitely
anything that could get worse in the future? As
You-
long as I keep my diet and exercise good. Like, is there anything that my body could do worse in the future that you would predict, or?
No, not
Okay.
too much. I mean, if it really is type 1, or if that's where you kind of settle out, and that's what we can definitively say, then like an insulin pump would be good.
Okay.
There's some stuff on your CT. None of them were masses or
You
anything
said
else.
cysts, right?
Yeah, they were thinking they're cysts, but they're saying, maybe do an MRI or something.
Like
that.
today or something?
Could try doing it today if you're
Yeah,
up for
I'm
it.
up for anything, sure.
Yeah. I don't know if we'd be able to get it today, but we can definitely try it.
I know people like, because it's Sunday. I'm like, people get sick and die on Sunday. You gotta have it every
No.
day. Things
That-
can't close down, but when we were looking for pharmacies, some of them were like, oh, our pharmacy doesn't do on Sunday and our pharmacy this and
That's
that.
right.
So you're thinking that maybe some of the masses could be something else and you just want to check them out.
Just better characterizing. Yeah.
Okay.
It typically good idea when the radiologist says, "Hey, I want to look at this."
Yeah, because they need to be clear and not have any thickness to them, right?
The cysts.
Yeah,
The
or
cysts
anything
are
that you're
typically homogeneous, meaning that they show up as the same color.
Okay.
When we do the imaging, if they are contorted or if they look what's called heterogeneous, sometimes you have to worry about things like abscesses or even masses. So
Okay. So, and that's because nothing else is giving a reason why, so you want to do that one last check. Or the
don't
radiologist
think-
just looked at it again and said, let me look.
yeah, I don't think that those probably have anything to do with the diabetes,
Okay.
but they, you know.
Could be something in the future.
Yeah,
might
like
as well
let's say
take
in
a
2 years you have liver cancer, and
Yeah.
this was the beginning of it. We never looked.
Right, I
like-
got you.
Yeah.
Okay, so the pills are gone, so I'm going to be full insulin.
Mhm.
And a pump, someone was talking about, like, I don't really know what a pump looks like, even though my grandson has one, he didn't ever show it to me. Is it like about the size of a little flip phone that goes on top of your skin?
Yeah, they're all different, but yeah, so they're typically about that big.
And what holds them on or in?
So you have a little needle that'll go in,
Mm-hmm.
and then typically some people will just have the insulin pump with them. They'll put it in a pocket or something else.
Oh,
Other
so
people
you're
can have a
covering,
little
so
something
it's like
to
having a
keep on.
port. The port is under your skin, and then the pump you attach when you need insulin?
So
or-
it's like a disc,
yeah,
most of
like
them,
the same
and
thing
it has
on
a
your
little
arm.
needle, and so you stick that needle in with the disc on the outside of the skin, and then when you need to, you can't keep it in the same spot all the time.
Okay.
It's got to move, and so you'll have that in for however long, and then however many days will go by, and you'll switch it to a new site. So the needle goes through the skin; it doesn't sit under the skin.
Right, okay,
If that makes sense.
okay. So I'll have a thing on my arm
Mhm.
and a thing that's waiting for the pump to go on when I need to have insulin.
So you're gonna go home with pens,
Okay, yeah, that's right,
yeah,
okay.
and then they can set you up with a pump outside.
Okay, okay. And is the system the same way they do in the hospital? I check my blood sugar first,
Mhm.
and then decide what I'm going to eat, and then figure out how much insulin I need according to what my number was?
Yeah, so immediately you'll have the insulin once a day at night, right? And that's
Right,
the
the long
long
one,
acting,
yeah.
right? And then the short acting ones, we'll just give you a correctional scale for now instead
Okay.
of having to do carb counting and stuff like that.
Okay,
And they'll teach you the carb counting stuff with diabetes education, which we'll get you set
Okay.
up for too.
okay. And so I really just need to, what should I be shooting for on a constant level of the
So
number?
we typically want you between 100 and 180, but really
Okay.
that A1C, right? The goal is to be at 7. So
But I can't check my A1C myself.
no,
So that's something that like set me up for maybe in 3 months I check it.
your primary doc, yeah.
Okay,
Or
and
the
by
endocrinologist.
eating better and like taking care of my insulin levels and my sugar levels, the A1C should naturally go down, and then I'll have like a new level of that, and that's what I want to try to stay at.
Yeah, so what the A1C is we take a look at what percentage of your red blood cells have sugar crystals on them,
Mhm.
essentially, right? And so right now you're at 10%. 1 out of every 10 has sugar crystals. We want that down to 7%.
Okay.
Right.
And all the time I've been in the hospital, I've never been. What did you just tell me my new normal should be? Under 200, right? I should always try to be.
The glucose?
Yeah.
Yeah.
So I've only been like 183, 199.
Yep.
So what does that mean? Because that makes me a little nervous because I've been in the hospital and they've been monitoring me
Mhm.
but so I'm a little nervous that I haven't ever been that level in the last 4 days. So what does that mean?
It doesn't mean much.
Okay.
Yeah, so it's essentially a work in progress to start,
Okay.
right? What we don't want again is to give you low blood sugars.
Right.
So we'll allow higher blood sugars, but
Okay.
then we just keep increasing until we.
So my
get
ideal
that.
is 199, under 200 and above
180.
180.
Yeah.
Okay,
We don't
180.
want you under 180.
Okay.
We don't want you typically below 100,
Right.
but technically anything above 70 is okay.
Okay.
So
And my daughter-in-law, who's a nurse, wanted me to ask you about stress because you were checking my cortisol. What does it mean when I have a low cortisol, or even when you stimulated it only went to 2.4? Does that mean that I handle stress good, or I don't handle stress good, or what does that mean?
no, so what that is we are inducing secretion of your cortisol.
Okay.
So costotropic test is basically us saying, all right, here's your baseline. We're going to give you this, and we're going to give you this drug that's going to stimulate cortisol, and we're going to check it at these time intervals. And what we just want to see is that it goes up, right? We want
That it's
the
working.
hormone that we're giving you to induce cortisol secretion. So all we're doing is basically like, let's say it's a car, right? You have gas in it, you turn the ignition on, and now you press the gas pedal and you expect something to happen. And
Okay.
that's what we're doing with
And
the
so
drug.
did what you wanted to happen happen?
Mhm. Yeah,
Okay.
it went up on all of them. You secrete cortisol.
Okay. And then also, like, say that, like you said, in the last 3 months, I've pretty much been coming up to getting diabetic. I've been pre-diabetic for 3 months from what my blood cells show. Is that caused, or could it have been a symptom, or I guess a reaction of lots of stress, or no?
No.
Okay, so there's nothing that makes you have diabetes other than unless you're getting type 2 and you're eating a horrible diet.
Yes, but I mean, there's some genetic components to it too.
Yeah, okay,
Like my wife's aunt is, 5'6", 87 pounds, and she's type 2 diabetic, horribly type 2
Yeah.
diabetic.
And
So-
she's very tiny.
She's tiny. So
But how did she find out? How did it manifest itself, or when
they
did
all
she?
have it.
Oh, okay.
My wife's mother.
So they're just
her
waiting to
sisters.
get it, and it's whenever your body's pancreas stops working.
No, so for them it's just that I don't know if it's a receptor problem in their family, but
Oh, okay.
they'll
It's not a
develop type
pancreas
2
thing.
diabetes.
Okay,
But for type 1, it's loss of being able to make insulin.
okay. And are there any negative side effects with insulin and not having your pancreas work and stuff?
You could kill yourself very easily with insulin.
Oh, okay.
Yeah. So it's side effects. No, I mean you're going to
Okay.
gain weight probably using insulin
Okay.
because if you haven't been secreting enough insulin, right? And now you're going to be you're going to be having more insulin. Your body's going to take in more calories on the cellular level. If that makes sense.
But you're eating so clean.
You can eat clean.
Okay. But
But
you'll
the-
still gain weight.
A lot of people do.
Okay.
Yeah, just because right now you eat, right, and that sugar goes into the blood and it just stays there until you pee it out, right?
Right.
And as those numbers go up, you get more thirsty, and then you pee more and more and
Yeah,
more
yeah,
and more. And that's because that glucose is just sitting in the blood. It's not going actually into the cells to be metabolized, right? So now we're giving you insulin, which is going to take all that sugar and put it into the cells where it can be used.
Okay.
And so now you have a whole bunch of extra energy.
Okay.
and so that's
why you have to exercise. Exercise is a good thing for every diabetes.
Exercise is a good thing, but type 1 diabetes does not have to do as much with any of that.
Oh,
It's
that's
not
all
a
the type 2,
reversible
yeah.
thing. It's not
Yeah.
something that you can reverse. So,
Okay.
jeez.
People want you this morning.
They want me to go see someone in the ER.
Oh, that's important. Okay. I think that's all my questions.
Okay.
Anything else? So we're gonna have an MRI.
Yeah, so let me
Okay.
see if we can get the MRI today. If we can't, then we'll plan to do it outside the hospital. It's not urgent. It's
Mhm.
just convenient. It's
Okay.
usually here.
Yeah, I'm here. I'm in a gown. I'm in a bed. So let's get her done if we can.
Exactly.
If not, would I just stay one day and do it tomorrow?
If you want to, we could. Again, it's not an emergent thing, and so you could do it outpatient even if you want.
Okay.
It's up to you. You'll have 2 pens at least, right? You'll probably have is the Lantus pen and then a box of pens.
Mm-hmm.
And so the Lantus one you'll give yourself every night, right? And
That's the
even
long
gonna-
range one. Yeah.
And we've been increasing that every day because, like you said, you're not getting into
Down
the
enough. I'm
100
not
to
getting
180s.
100. Yeah.
So what we want is in the morning when you wake up, we want that sugar to be like
In the good level.
Yeah.
Yeah, I was
100 to
203 this
120.
morning. I'm like 203. I'm starving. I haven't eaten anything since dinner, and I should be low, but I wasn't. So
Yeah, you should be definitely in goal. And so if you're not in the morning, it typically means the long-acting one needs to go up.
Okay.
If you're throughout the day after you eat and before bed, you're still high, it means that the short-acting one needs to go up. Does that make sense?
Mm-hmm.
So short-acting, long-acting.
Yeah. Okay. And the only difference between the pen is it holds more in it, and you use it slowly, and the other ones you use one time, right?
No, so how these pens work is you'll put a needle on it, but you just twist the end,
Yeah.
and the button will kind of pop out. And then you stick it in, you press the button, and it delivers the dose.
There's still more insulin left in it for another time, so
Right.
you're reusing the needle in that case.
You don't reuse the needle, but you reuse the pen.
Oh, okay.
Yeah.
Reuse the pen.
The
Okay, that's right.
needles can
You're
come
attaching
on and
that
off.
little thing that you peeled off like the copy tab and put it in. Yeah.
Yep.
And then the night ones, they're all just one use only. That's
Those are the same thing. So
Oh, okay.
Lantus will just have the dose in it, and you can ratchet up the dose.
Yeah.
I'm not sure how many. I think they're all different because you have a U300, U100.
so it's
those
kind
are-
of like a
those are
sword,
very
and we just use them. And then on Tuesday when I go see the regular doctor, which I've never met him before, so he's going to be like, "Oh, what a new patient I'm getting."
Mhm.
So he will write me a prescription, and then as I need them, I'll go just get them like.
We will give you a prescription today.
Okay.
In fact, I think we'll probably give you the pens
Okay.
before you go home.
Okay. And then I can talk to him about a pump. How soon can you do a pump after?
It'll be him so one, we need the dose, right?
Yeah.
We need to see what a real dose is, but he may send you just over to endocrine. The problem is endocrinology, there's not a ton of them. And so getting
Maybe
into
a while
them
to
can
get an
take some time.
appointment.
Yeah. Those are the real pump experts, right? They know all the different stuff that's always coming
Mhm.
out. But yeah, and then we'll see if we can get you the CGM. The CGM should just connect to your phone, and you can just look at the.
CGM is the button that goes on your arm, right?
That's right.
Okay, so I'll go home with the button, and also the thing that you stick the little strip in and test your blood just in
Yep,
case.
the glucometer.
So when would you know to use that? Would you be like you?
If we get you CGM, you won't have a glucometer.
Okay, but then they still said if it doesn't match what you think it should be, then you should test it with the glucometer because it takes a while for this to register or something like that.
Yeah.
Okay.
It kind of depends on what the insurances are going to
Okay.
give to you.
TRICARE standard, so whatever
Yeah.
TRICARE standard does.
Okay. Cool.
Okay, that
You're
sounds
gonna get some
good.
goodies, and then we'll see if we can
Alright.
get the MRI. Okay.
Thank you so much.
Yeah. Good to see you.
Okay.
Take care.